All right.
Okay. So my case today is a patient that I've had probably for about 10 to 12 years. Ever since I've known her, she has had diabetes, been a heavy smoker, hyperlipidemia, and overweight. For years, she tends to follow up every 6 to 12 months, often because she doesn't have insurance, and she tries to keep costs down. She likes to skip out on labs, anything to keep costs down. Over the years, I've adjusted her medicine to try to keep her A1Cs under 7. We've tried different medicines for her hyperlipidemia. Once when her A1C jumped above 7, I added some medicine, and she confessed to me that she wasn't taking her current medicines as they were prescribed. She was only dosing them once a day instead of twice a day, and that she promised she'd start taking them if I wouldn't add anything, since she hadn't been taking them as prescribed anyway. So she's been a little tricky to treat because sometimes I think she's doing what I ask, and she's not. We also had some trouble with her hyperlipidemia. She was intolerant of statins, and I had a real difficult time getting her to take anything. Eventually, I did get her back on a low-dose statin. So over the years, we've managed pretty well. In the winter of 2018, she had a flu-like illness and ended up having an episode of CHF. We referred her to cardiology at that time, which she reluctantly agreed. Again, she had no insurance, was paying out of pocket, and she saw a cardiologist at that time. She had an echo then, and her ejection fraction was 35%. Started on some Lasix and continued on pretty much the same course. I mean, we're managing her diabetes. Her A1Cs are around 7, maybe a little above, maybe a little below. Continuing to deal with her hyperlipidemia, which isn't severe. But in December of this year, it was on Christmas Eve, she had some numbness and leg weakness. She went to the hospital by ambulance. She was diagnosed with a TIA, found to be an atrial fib. She had a cardiac workup and ended up having a heart cath. During the heart cath, she went into VTAC. She was shocked successfully and was transferred to CAMC. When she was at CAMC, she ended up having open heart surgery. At first, they just did the LAD, but when she was in recovery, she had an episode of VFib. They took her back to open heart surgery. They also did the marginal branch of the circumflex and the right coronary artery, and she recovered. At that time, her ejection fraction was found to be less than 10%. And after being in the hospital 20 days, she was discharged home, and she followed up with me, I think on the 17th of January. So I tried to be real careful with her, going over her med list, making sure that the list of medicines I had was indeed what she had on her shelf at home. Is there a list of meds attached to this?
We have just this case form right here, and this is everything.
All right. So at her follow-up visit, her vitals were good. Her blood pressure has been running low, and I think her blood pressure at the time of her follow-up was 112/80. Pulse was in the 80s. She was still in AFib at the time. She was supposed to be wearing a life vest, which she was at that time. She's since stopped wearing her life vest. Let me think. As far as the medicines that she's on, she was on medicine for diabetes, the Janumet. She was also on some insulin. They had put her on amiodarone, Lasix 20 milligrams once a day, losartan 25 milligrams, metoprolol, aldactone, Crestor 5 milligrams. And she said she was taking them all regularly. We did some labs the day she was here because it had been about a week since discharge. And on the labs that I got back, her BUN and creatinine had changed. She was doing pretty well in the hospital, but BUN was up to 32, creatinine was up to 1.5. And that's where I called Dr. Doyle and I said, hey, what am I going to do? And he said, well, why don't we just hang tight? And one of the things that I thought was going on with her was, since she had been discharged, her blood pressure had been very low. And on the discharge note, I noticed they had losartan 50 milligrams, and she was really supposed to just be taking a 25 milligram dose. So I almost wondered if she was taking the 50 milligrams versus the 25. Maybe it had dropped blood pressure, and maybe that was part of the reason we saw the problem. So I double checked that with her. And we ended up just waiting, and her BUN and creatinine came back down 21 and 0.8. She's had some trouble with the wound on her right leg. She's being seen by a wound clinic now. She has a PICC line. She's getting antibiotics 3 times a day. She just had a really rough course. And as far as her ability to take care of herself, it's somewhat limited. She lives alone. She's unmarried. She doesn't have children. She has one sibling that lives nearby. He doesn't have a driver's license. So she depends on friends, and it's difficult for her to get to appointments here. And the appointments with the specialists in Charleston are especially difficult for her to get to. Like I said, compliance has been an issue because of cost. She is getting Medicare, which I don't know a whole lot about. Traditionally, my patient population is adolescents. I work in a high school wellness center. So I don't deal with Medicare a lot. And we've been on the phone with her a lot about changing medicines because she's worried about co-pays, and with the new medicines that she's on, some of them are very pricey. So a couple questions that I had for Dr. Doyle after getting her renal function worked out was, should she be on something like Entresto? Again, cost is a huge issue, but then in looking at some of the guidelines, it seems like it's recommended, and I'm not sure if that's just because it's the new kid on the market, or is it really worth trying to push that? And then also with her diabetes, maybe putting her on a GLP-1 versus the Genumet and insulin that she's on. We had actually discussed the GLP-1 before all of this had happened, and she was worried about side effects and didn't want to do the medicine because of side effects. But I'm wondering if this might give her a little bit more help with her CHF.
Thank you so much. That was excellent.
Yeah. So I have a lot of stuff to say about this. That's a great case, and not something that's unfortunately not all that uncommon. So, so I would say, I'm with Dr. Doyle. I wouldn't have worried about that creatinine bump either, because typically, particularly when you described her whole scenario in the hospital and the post-operative complications and the need to go back, I mean, I'm not shocked at a little bit of bump and things. And remember, every time you start an ACE inhibitor and an ARB, you should expect to see about up to a 10 to 20% increase in your creatinine. So, so that is not uncommon. Actually, that's we see it all the time. So I don't get concerned about that. Two is as far as your question on, I'll go to the Entresto first. So I absolutely would change her to Entresto. I think the data is robust, and it's not just morbidity data, it's mortality data, so it reduces hospitalizations and also reduces your mortality at 5 years. So long-standing outcome data. So I absolutely would do that. If depending on her income, she should qualify for the patient assistance network with Entresto. And if you need any help with any of that, we can, my office has some information that we can share. We'd be happy to share that with you. But that should be pretty easy to get her covered on that, especially if she's not, if she's eligible, she's getting Medicare now, she's going to qualify. So she'll at the most, she'd pay be $10 a month with Entresto. I don't even think she'll pay that based on what you're telling me. So absolutely do that. And there's some easy conversion guides from dosage of losartan. So if she's on 25, you'd probably put her on low dose of Entresto. If she's taking 50, you could do low to moderate dose. But really importantly is you absolutely want to continue to try to push the dosage of that medication. Each of the dosages are the same price, so you don't have to worry about cost with the dosages of those. So you absolutely want to do that. I highly recommend that. With respect to diabetes, I mean, we have such good data now with medicines like Farxiga and Jardiance with heart failure outcomes, whether they're diabetic or not. If they're diabetic, great. She's diabetic, so it doesn't matter. But we have data now to use them even in non-diabetics with heart failure. Now, I would say I would probably wait to do that until her wound infections cleared. The one thing with the Jardiance and Farxiga is they make you more prone to UTIs, and I don't think you want to mix the picture up with her being on antibiotics and have a fever or anything like that. They only make you more prone because you start urinating the glucose out, and that's how the mechanism of action. So, and then there's been reported cases of gangrene and like in the genital area, Fournier's gangrene, those sorts of things. And that's actually had a black box warning in some of those medications. So I would say you definitely want to wait, but I would do that eventually for sure. That's my opinion.
Okay, thank you. Another question that she's had is about the Eliquis. And that had to do with Medicare paying for Eliquis. And we talked about different novel oral anticoagulants, and then even the thought of Coumadin, which I'm not sure she could keep up with the follow-up on coming in for the labs. So any suggestions on continuation of that?
So the same, I mean, so I don't know, did she have, during her surgery, did she have a maze procedure? Is she in sinus now or not?
No, she's still in AFib.
Did they, one thing you could talk to them is, did they remove her atrial appendage? Because usually a lot of times during CABG, they'll take out the atrial appendage, and if they did a good job, then you don't necessarily have to be on anticoagulation after that, because that's really your risk of stroke is clot forming in the atrial appendage. So I don't know what they did, but so that would be something you could talk to the folks in Charleston about, of what they did. But if you're going, how old is she again? I apologize, I didn't catch her age.
64.
64. Okay. So I would say, I would continue it for now until you find that out. There's also a patient assistance for the Eliquis as well, and pretty reasonably easy to get for these folks. So not too difficult. I mean, it takes some time to fill out the paperwork. Again, we're pretty blessed in our office. I have a social worker in our office that helps us with that stuff. But even so, it's just a matter of, even if you talk to the reps locally, the drug reps, they'll help you with that. And believe me, they want their products sold, so they're going to go out of their way to help you.
Okay, thank you.
But we can give you some stuff too. So I can get some of those forms to you via the Echo Center, and they can email them to you. That may take me until Monday because I'm actually in outreach office today, but I can get that to you.
Okay, thank you.
Yeah, it sounds like you guys did a really nice job on her. I mean, I would continue to push the meds. I mean, remember, you want to get to the gold dosages of all those medications. So for metoprolol, I would make sure that she's on succinate, which is Toprol. That would be, the gold dosage of that is 200 milligrams a day. Now, you're not going to get there overnight, but you want to continue to try to push that dosage. And for the Entresto, the gold dose is 97-103 combination there. Did you say she's on aldactone or spironolactone as well?
She is 25 milligrams once daily.
Okay, and that's the gold dosage there, so you're good there. And then did you say digoxin as well or no?
No, amiodarone.
Yeah.
And then
So that, I mean, to me on the amio, this is what you definitely have to have some follow up with them there. I mean, she took the Life Vest off. Is that right? She can't stand the Life Vest.
yes.
Are they planning to repeat an echo at any time?
Yeah, I think they were going to repeat it in 90 days and then talk to her about an implantable defibrillator.
Yeah. So I mean, she's. So how many days post-op is she now?
She had it on the 3rd of January, so I guess almost about 60 days.
60 days. Okay. I mean, the highest risk for cardiac events post MI and post surgical is like the first 30 days. So I mean, she's still in the risk area. So I wouldn't stop the amio until you know what her EF is, and if you know the setting of VT and VF in ischemia and post-operative like that, that's probably like a reperfusion type of injury after surgery, and then they went back in and opened things up. So I don't know how long they're going to feel strongly about continuing the amiodarone. That's kind of not knowing all the details of what happened post-operatively. It's kind of hard for me to tell you that, but I would definitely talk to them about that. I think she's going to definitely have to make that follow-up appointment for the echo and then discuss all those other things.
So,
But in the meantime, I would continue to push the meds for sure. I mean, what I like to do if I bump the Entresto, or if even I switch to Entresto, I like to get labs the day I do it, and then a couple weeks later, just to make sure potassium and renal function stay okay. Because you can't see that, more than 20%. You want to be sure, and patients tend to have the biggest, if they're going to have a problem with it, more times than not, it's because they're dry. So over diuresis. So is she still on Lasix now or no?
she is. She's back down to 20 milligrams once daily.
Once daily. Okay. And when you make the change to Entresto, you may be able to come off of that because the Entresto has more of a diuretic effect than just losartan. It's the sacubitril portion of the drug, which causes it inhibits the breakdown of BNP, and that's why they tend to have a little bit more of a diuretic effect. So oftentimes, if you're on a low dose of diuretic or even on a little higher dose, you're able to come down a little bit. So just something to keep in mind to watch with her. And it's more potent. So, you're going to have to watch your blood pressure closely when you do that as well. And not that much more. I mean, the nice thing about Entresto, it actually has a shorter half-life than losartan. So it's probably a little safer to bump to push that dose than it is to push the losartan. Okay, because if you push the dose of losartan, they get hypotensive. That's going to last a little bit longer than at least it's only like 12 hours with the Entresto. So little nuances that the more you use the drug, the more you figure it out. It took us a while to do it too, for that matter.
Now, as far as watching for exacerbations of the CHF and measuring BNP, when I was looking through some of the information, there was something in there about two types of BNPs, and with using one of the drugs, you needed to avoid using the newer type BNP. Does that sound familiar to you?
Well, that is a wonderful lead-in question to my lecture. So
okay.
We can talk about that because I talk about the two different types that we're able to test. But the short answer to that, and I'll go into the detail behind it. The short answer is typically when you start Entresto, you inhibit the breakdown of BNP. It doesn't touch NT-proBNP, which depending on your center, which one you check. BNP is a breakdown product of NT-proBNP. It cleaves off, and I'll show you what those molecules look like in my talk. But Entresto can affect the levels of BNP and actually can increase them because you're inhibiting the breakdown of things. So you can be fooled sometimes with when initiating Entresto, when you're measuring, if you're relying too much on just what your BNP level is. I use BNP as a kind of a guide. I think I use it as, I don't, that's not, we've done a study that shows using BNP alone to adjust your medications is not the right thing to do. Because we had a study that I was a part of about 5 years ago where we looked at, okay, let's only adjust our medications on BNP levels alone, and that's it. Because people thought if you're able to get things down, then there's no point to continue to try to titrate the medications. Absolutely the wrong answer. That is not the right thing to do. We know the outcomes are not as good that way.
Okay.
And that was a national trial. That was from out of the Duke Research Center, and so that everybody feels comfortable with that. What I will tell you is, and there's a lot of disagreement on, is how often do you check it? I typically check it at most of their office visits when I'm in more of a maintenance phase. And early on, when you're making all these adjustments, it's difficult to know what to do with it, right? Because so if you have blood pressure, you're pushing your medications, and your BNP is still high, is that going to stop you from pushing your medications? Probably not. It may make you think that, do I want to not back off the diuretic or not? That may help you with that sometimes. But I never use it by itself. I like to do, we have a portable ultrasound machine. It's called a Butterfly. And we plug it, plugs right into your iPhone. And so we look at people's inferior vena cava, and so can tell if it's collapsing or not. That's how I make a lot of decisions on how someone's dry. So it's a much more accurate way of looking at the jugular venous pressure, right? I mean, that's basically what I'm trying to do. Can't do that. I understand you can't do that, but that's one of the things I'm trying to do. At some point, I'd love to try to get a multi-site trial with PCPs throughout the state to use that, because they're not that expensive. They're only $2,000. I say only, but when you look at what other devices cost, as far as a full-blown echo machine, you're talking about $20,000, $30,000, versus something that you could plug into your phone or an iPad and get peripheral studies. And I think it's a fantastic device. But that's something we're looking to do. So stay tuned for that. I'll loop people in to the study, throughout the PBRN and whoever else wants to be a part of it, because that's something we really want to try to do. Because I do think it's going to be a show of benefit. It's not that hard to learn either. Trust me. But back to that's a long-winded answer, and I diverted off there a little bit. I use BNP. Yes, I absolutely do. If I'm seeing someone at 3-month intervals, that's typically what we do. Once I have someone stabilized, I would see, a couple times a month right now. I mean, especially while you're making adjustments, I'd probably see her every 2 weeks if she's willing, if she's able to get to you. I mean, I think sounds like it's more convenient for her to be able to get to you. So those are things that you can. I would do that. I'd probably check her BNP once a month, just to kind of get some trends. And that's really what you really want to know is, okay, I think I've maximized everything. She's feeling pretty good. Where's the best I can get my BNP? Because what you get out of BNP is it's more prognostic than anything. It tells you what's going on, but it's more for, okay, am I going to see trouble? Am I going to be more likely to see an admission coming up? Those are the kind of things. Or is this someone I can't ever get her BNP down? She's at high risk for having bad outcomes long term. I think that's how you can utilize the test.
Okay.
It's not cut and dry. I mean, I can tell you a lot about what some of the studies have done. A lot of it gets into the art of using it, because you have to kind of get a sense for, okay, everybody's a little bit different too. And what you will see is you'll see absolute fluctuations in BNP early on when you start Entresto, 100%. That you will see. And that's not the time to necessarily make treatment decisions on what that level is. Because I have several people on Entresto months out that their BNP levels are normal, right? And you'd think if that's inhibiting the breakdown of BNP that you'd still be a little bit high, but they're normal. So that's why I say I don't think you can say with certainty that using a BNP you can't do it. I prefer NT-proBNP, but that's not the test we have in our center. So I have to use BNP.
Okay.
So you have to learn to live with it. Whatever you have, you have to learn to live with.
I think that's all we have.
It's a big deal. to change it, because it's very costly to change the system you use, especially because they tend to run it on a big. This is stuff I learned because when I got to WVU, I wanted to change it, but it was going to end up being a huge deal to make that change in the lab, just because they run it along a bunch of other blood work that they do, and it would have cost a lot of money. So I got vetoed pretty quickly on that.
Thank you both so much for that. And thank you, Melody, for the excellent case. We really, really appreciate it. I did want to ask everyone out there if there were any comments, questions based on the case that Melody just presented for us or the discussions that were just going on.
I'd like to know, did everybody like my cool background? I just realized I could do that on my phone today.
It's really cool.
Yeah, right? Well, that's like the only thing that's the fun thing I got on here. Come on.
It's definitely nice. Better than the wall we have here.
That's right, see? It's simple.
Yeah. All right. Well, if anyone does think of any questions, feel free to shoot me an email. I'll make sure to have it addressed. And thank you again, Melody, so much. We'll make sure to have the recommendations sent back to you sometime, hopefully next week on Monday. So I noticed a lot of people actually jumped on from the start of our session. So if you could please just chat your name and where you're from, that would be excellent. We would really appreciate that. So Dr. Sokos, if you are ready, I can pull up your didactic for you.
Right. I think what if we do this to start with? We haven't been hit yet. The first you want to just go through math, and then as we kind of figure it out, you guidelines.
All right.
From there.
Are you able to see that okay, Dr. Sokos?
Can you put that on presentation mode? I can see it.
Yes.
Okay.
All right.
All right. I think
Okay.
I'm going to turn my phone sideways, so if you're looking at, I can see the slides better that way. So,
Okay.
All right. You going to advance for me?
Yes, sir. All right. Just say next slide and I'll do that for you.
Okay. So, Melody, I just want to say that was an awesome case. I think, honestly, nothing against anybody who's presented cases previously, but that's one of the best cases we've had in the cardiovascular sessions. So I would love to have more like that, because these are the kind of conversations we want to have. And I think these are the kind of, I think we can help you in everyday practice, which is the whole goal of the ECHO program. So, so you asked about BNP and NT-proBNP. So, I think, we kind of have to go back a little bit and understand that those tests are biomarkers. And there's lots of biomarkers. But basically, what is a biomarker? So it's a substance that we measure that serves as an indicator of a biological state. That's a nice fancy term for. We use it to assess the progress of disease, and when we treat patients, how the effect on the disease process. So simple tests, blood work for the most part, and we're able to utilize them to help us understand our treatment decisions and what and how our patients are responding. Next. So what about, I'm going to focus on heart failure because I think it's the easiest thing for us. I think, when we start getting into troponin for acute coronary disease, there's a whole lot of other issues, and that's a much harder topic to discuss. If we can always talk about that at some point in the future, but I'm going to focus primarily on heart failure. So it helps us with the diagnosis. It helps us with understanding the severity of disease, and it can be a surrogate for how people respond to disease. It's kind of what we were talking about. Next slide. So there's a ton of biomarkers that people have studied in heart failure. I know we tend to think of BNP, NT-proBNP, but there's a lot of data on troponin too. And there's a lot of these other markers that we can use, but are not as easily accessible, right? It does you no good to have a fantastic biomarker if you can't run it pretty quickly, get an answer back quickly, and use it, right? So if you get these tests back and it takes 2 weeks, especially in heart failure, things can change within the same day. And so if you have to wait that long to get a test back, it's not really all that helpful. So out of all these ones, next slide. I'm going to focus on basically troponin and BNP and NT-proBNP. Okay, so I think this is a very, very important thing to understand. When you have someone who comes in with acutely decompensated failure, extremely common for them to have elevated troponin levels. And I think you need to understand that if someone has heart failure and they have an elevated troponin, that doesn't necessarily mean they're ischemic. Okay, that doesn't mean it's an acute coronary event. It doesn't mean you need to do a cath necessarily. You may need to, and you may need to go that way. But especially if you have someone who's a known, let's say you have someone as a patient, you have someone as a known non-ischemic cardiomyopathy. They don't have coronary disease. They know they have heart failure. They come in. They're extremely volume overloaded. You need to admit them to the hospital to diurese them. You check a troponin, it's going to be elevated. And why is that? Because you get stretch on the ventricle, both right and left ventricle from volume overload, and you're going to see an increase in, you're going to see release of troponin. The stress on the cardiac myocyte, that's going to happen. So we know that's a fact. So you don't necessarily, and we call it heart sweat, in my group, because we see it all the time. You see a little strain on the heart, they bump their troponins a little bit, and as you treat them and you get their heart failure better, their troponins go back down. So it could be, I'm not saying it can't be, an acute MI, but you have to put the whole clinical picture into place. So, and it doesn't mean if someone's non-ischemic at one point, if they have other characteristics of their presentation, which suggest, an acute ischemic event, that doesn't mean you don't look for it and close it off. It just means that try to use things in the context of the patient. You have to pull that all into play. So I think it's really, really important to do that. Next slide. So here's a study that's from 2008 that looked at the risk associated with elevated troponin levels. So it looked at the risk of death, which you can see is significantly is a significant elevation. So it does portend a prognosis. Doesn't mean it doesn't mean anything when it's elevated. I go back and I say it doesn't mean that they're having acute MI. The higher the troponin is, the more likely you are to have a bad outcome during a hospitalization for heart failure. So, and if you look at measuring troponins serially, can predict your risk of hospitalization is there as well, and it can predict death or hospitalization. And obviously, you have to think about that when you're thinking about myocardial infarction. Next slide. So if you look at this slide, this looks at troponin T and looking at the hazard ratio and basically how high, if the higher your troponin, basically the higher your risk for hospitalization and the higher the risk for mortality in heart failure patients. So basically it just tells you it's kind of a linear test. So if you have it, it's higher, then you should, if you see it, it should trigger in your mind that, okay, I know my troponin's up in this patient. I'm not thinking that this is, I may or may not be thinking, you have to think about that in your mind, but the biomarker itself that you can utilize it for you to understand that if it's higher, it puts this patient at a higher risk for having a bad outcome and a higher risk for an event. And it's important to look at that because I think knowing what to do with your test results, and because if someone comes to the ER, think about it. How many patients do you see they come into the ER, they're short of breath, and I think if you come into the ER and you stub your toe, you're going to get a troponin and a BNP and plus or minus a CT of the chest to rule out PE. At least that's for all the patients that we see, a lot of those tests are already done. So I mean, I think you need to know how to respond to those tests because when they're done in a method like that as a screening tool, you have to understand where to go with them after that. So I think knowing that they're high, knowing that they portend a worse outcome, that helps you understand where to put the patient in the hospital, what to do with them next, how aggressive you want to be, and also helps you to explain things to patients to where their risk is. So I think it's really important. Next. Okay, here is, well, your question as far as what's the difference between BNP and NT-proBNP. You can see that the NT-proBNP is a much larger molecule, and that the BNP molecule gets cleaved off of there. So when we look at the difference of levels, NT-proBNP levels are significantly higher than BNP levels. So it's really important to know what test you're getting back. This is a problem I had in EPIC a couple of times, where someone put in an NT-proBNP under BNP, and the last time I saw them, their BNP was 200, and the next time they come in, it says it's 4,000. And I said, what the heck happened? My patient, she's looking in the room, she feels fine, nothing's going on. And when I realized there's some hospitals within the system that run NT-proBNP, and it got put in under the same line as BNP. Now they've corrected that, but that's important to understand when you go back and seeing your patients, even if you're getting labs to you in a paper copy from an outside facility, you need to know how to compare the two. And plus or minus, it's about 10 times higher than an NT-proBNP, about 10 times higher than BNP. That's a rough estimate there, but something to understand. So you really got to pay attention to what test you get back. Both of those tests are available as point of service. So if you're in a really remote location and you ever run like an iStat labs, if you want to do like a finger stick where you can get, like a BMP, basic metabolic panel, they have the cards that have the BNP on those as well. So, for us in the hospital, it's not cost effective to do that, but those kind of things are available. Next slide. Again, this is a slide just talking about the different assays, how it's easier to where you're looking at the triage assays versus Roche. So you can go next slide. I just kind of want to show that you have different tests for that. Okay, so utilizing BNP for a diagnosis of heart failure. This trial is a pretty old trial, but it still holds true. You go back, this is from 2002, so it tells you it's almost 20 years ago, how far back our data on BNP goes. But if you look at comparing clinical judgment to a BNP of greater than 100, and using clinical judgment and a BNP greater than 100, look at your accuracy of diagnosis. So clinical judgment stinks against BNP. So BNP actually is a great test, but you have to be, and it's very good at helping you diagnose the problem. What you have to recognize is that BNP levels can be affected by multiple things. So think about this. If you have someone that comes in and they have an acute PE, that's going to place a lot of strain on the right ventricle, right? Because with an acute pulmonary embolus, the pressures inside the lungs go typically very high, in the 50 range. So you can go from a normal PA pressure, which is about 20, to a pressure of over 50. That puts a lot of strain on the right ventricle. And that's how BNP and NT-proBNP are released. The muscle stretches, that's released. It tries to tell the body, okay, we have too much stretch on the ventricle. Let's try to get rid of some fluids. That's why they cause an autodiuresis, and that's what you see when there's an acute reason for stretch. So hypertensive crisis can do that because it puts a lot of stress on the left ventricle. So there's a lot of things that have cause and effect that you have to understand why those levels are going up. So understanding yes, these tests are very accurate, but it's also, you have to understand some of the underlying processes. So I don't want you ever to rely just on these biomarkers. Biomarkers, in my opinion, are there to enhance your clinical judgment. Even though this study didn't show a whole lot of difference with using clinical judgment and BNPs, this was done in an emergency room. These aren't people. They have so much. I mean, I feel for my ER brethren, because those guys have and women have much. They see people coming with short of breath all the time. It's very difficult to discern the cause of it, and so that's why they run all these tests like this. I understand why they do it. Their clinical judgment is sometimes is jaded somewhat by some other things. So These tests are great to help you with some screening, but they're not the only thing. Next. This is a great slide that tells you that the higher your BNP level can correlate with worsening heart failure. Okay, so Lisa, just looking at straight BNP, and this is looking at patients who have class 1, 2, 3, 4 heart failure. We know that patients with who are doing relatively well still have elevated BNPs versus those who have class heart failure have the highest level BNPs. These are just looking at two different testing methods of BNP. So, really good data to tell you that the worse their BNPs are, it correlates with severity of disease. Now, this is just one study, but it's nice to know that, back to your question, Melody, when you said, okay, if I go back and check a BNP, what does it mean to me later? This can tell you that even the patients tend to downplay their symptoms, right? They tell you, I'm fine, because they don't want to go to the hospital. They don't want to do some things, especially if they don't have the insurance it's going to cost them. They really try to downplay it. When you have some nice objective measures, tell them, come on, the blood test is telling me otherwise. Are you sure? And I think it's good. It's a good test to discuss with patients about their true clinical symptoms and how much should you be pushing on their medications otherwise. I wouldn't just increase your Lasix dose because of a high BNP. BNP can be elevated by a high blood pressure. So sometimes you have a high BNP and you look and they don't look volume overloaded at all. Sometimes the right answer is to increase the afterload reduction through like an ACE inhibitor or Entresto or whatever else you're doing to help bring down that BNP. Again, you don't want to make the sole decision based on a blood test, but that can be helpful. Next slide. I'm having a hard time seeing this. I'm sorry. I got to move my slider out here a second. So this is looking at NT-proBNP and looking at levels. And I forgot my glasses today, so I'm scrolling in on my slides here, so sorry. So if you look at patients who come in who are not in acute heart failure, their NT-proBNP levels are significantly lower than those who have validated acute heart failure. There's a significant difference between the two. And the average, the level is significantly higher in the 2,000 to up to 10,000 range with the NT-proBNP. So basically, this is just showing you that NT-proBNP is just as good as BNP in detecting heart failure, right? You can't just go by one. You can't just assume that it is based on the physiology that I showed you earlier. Is how the two markers are derived. Next slide. And NT-proBNP does correlate with severity of disease. This is another study looking at the worse someone's symptoms are, the higher their NT-proBNP levels are. I won't belabor that. Next. What about the Holy Grail? What is that? Next. So if you put the two together, if you look at troponin and BNP, and they're both elevated, and you look at your risk, if you combine the two, you have a much better chance of making the diagnosis correctly and a much higher risk of mortality. So this goes to show you that if you have high BNP, high troponin, your mortality is much higher than someone who has a BNP negative, troponin negative, or BNP negative. If you look along the bottom there, I don't know if you can see that, but first one is the lowest risk is BNP negative, troponin negative, BNP negative, troponin positive, BNP positive, troponin negative, and then both of them together. So that gives you the best data. So you want to use all your information, right? I think, it's really important to get all that information together to make your assessment when you're looking at people. Next. And most of this data, I want to go back, is most of this data is when people present to the ER. This is not data we're looking at right here. This is not seeing someone in the office. So I don't get a troponin every time I see someone in the office. I get a troponin if they're getting admitted to the hospital. So I think BNP and NT-proBNP are good to follow over time as well, but I wouldn't get a troponin every time you see someone. Some people do. I just don't do that. Next. Next. These are the guidelines from the ACC and HA from the 2017 update. So this is saying, okay, when should you really get a BNP or NT-proBNP? So if you're trying to make the diagnosis and you are you're going to look at it up front. So basically, whether you're stage A or B, when you're at risk for heart failure, or you're at stage C or D, and they're having symptoms, class 3 or 4 symptoms, then you're going to want to use BNP to help you make the diagnosis. What you can also do is this is just showing that you can use it to follow them over time, and it makes it into to the guidelines as a recommendation. So it's not me just telling you that's what I think I like to do. It actually, there's enough data for now for it to make it into the guidelines. Next. So it's a level 2A to use in patients at risk of developing heart failure. So those are really for screening and early prevention that may prevent. So that's basically your your stage A and B patients. So they recommended against that before, but now if you're seeing these patients who say they have diabetes and hypertension, you want to screen them once a year with a BNP. There's some data that suggests that can be, it's a level of evidence B, and R means there's a randomized controlled trial. So we have data. I wanted to go through these to show you that there's a decent amount of data. I only showed you a few of the trials looking at these tests. Next. And basically, it's a 1A indication if someone comes in with symptoms of heart failure and shortness of breath to help you make the diagnosis. Next. Using them for prognosis and risk stratification, absolutely. So you can measure them at baseline on admission to the hospital. It's useful to make the diagnosis. Those are the studies that we talked about. So you want to look at what their admission level is when they come to the hospital. That's actually very prognostic, like we talked about from those previous studies. Next. I didn't mention this earlier. This is really, that's why I put this in here. I always try to get a discharge BNP or NT-proBNP so I know what they are when they leave the hospital. So that when I'm seeing them in follow-up and I'm looking down the line, I know what they were when they came in the hospital. I know what they were when they left the hospital. And then I can help them make some decisions down the line as far as their prognosis and what I'm going to do with them. So I think it's really a useful test for that matter. And then this goes to show the second part is the 2B recommendation, using them for chronic heart failure patients. So really trying to help you over those periods of time. Like I said, every 3 months, it's nice to use them at those time periods too. And it made it into a recommendation into the guidelines as well. Next. And that is it.
Thank you so much, Dr. Sokos. That was excellent.
Does that make sense for everybody? I mean, I'm happy to answer questions. Hopefully I didn't make things more confusing to talk for people, but I'm happy to answer anybody's questions. Everybody awake?
If there are any audio issues, you can certainly chat as well. And feel free to email us as well if you think of any, of course, after the fact. So if there are no questions, I did want to just mention that our next session is going to be on March 20th. And Rachel Brocious is going to be providing our didactic on when and what should you prescribe. So keep an eye out for that. We'll be sending out reminders as well as a recap from today's session. So again, if there are no questions, we'll see you guys next time. Thank you so much, Dr. Sokos. Thank you, Melody, for that excellent case. And we'll see you guys next time.
Okay. Thanks, everyone.
Thank you. Bye.